president and CEO of Aging in America, and has been in the field of social work since 1971, with the last 48 years being dedicated specifically to the field of gerontology. Bill, whose doctorate is in social work with a concentration in gerontology, was formerly the executive director at Cabrini Nursing Home, an assistant director of Francis Chervier Home and Hospital, as well as assistant professor of public health at Pace University and an adjunct professor in the School of Social at Fordham University. In addition to being a member of several committees, boards, and associations, he now chairs the board of directors of Cardinal McCloskey Community Services and continues to serve as a longstanding board member of the Westchester Public and Private Partnership. Dr. Smith is a licensed nursing home administrator, a certified social worker, and a certified retirement housing professional. As of September 2023, Dr. Smith has assumed the position of chair of the Committee on Aging at the United Nations in New York. So thank you, Bill, for everything that you do. And it truly is a privilege to have you on this call with us today for this topic on how we can improve social functioning in long-term care settings. And now, really, I would love to just hand the floor over to you. So with the global cafes, we do like to start off back to where it all began for us to really understand your personal journey. So with your incredible achievements and being recognized both locally and nationally as an expert on gerontological issues, could you take us back with you a little bit on both your professional and personal journey leading you to where you are now today with Aging in America?
Well, thank you, Roxana. First of all, it's a pleasure to be with the cafe amongst so many distinguished presenters in the past. I'm honored to participate in this program this morning, or this afternoon, or this evening, depending on where we are. I've been blessed through my career to really work with great organizations that allowed me to participate in the long-term care community and just to shape public policy and to deal with long-term care facilities or nursing homes, home care agencies, long-term home health care programs, home care, the whole continuum of services. So I've been very fortunate with that. But I've also had the opportunity to stand on the shoulders of giants in the field of long-term care. I've been introduced to many, many famous and just important people. And I'm just going to run down a quick list of them, some who are with us and some who aren't. But like Dr. Robert Butler, what a champion of aging services. Rose Dobroff was the dean and founder of Brookdale Center on Aging. She was one of my professors. Mary Ann Caranta, Dean Caranta from Fordham University, was my advisor with my doctorate. Monsignor Chuck Fahey, another world-known leader in the field of long-term care. Carl Pilmer from Princeton helped me with a special project that I'll talk about a little bit later on at the Francis Chervier Home and Hospital. Dr. Pupaello was another dear friend, but also an advisor. Dr. Bill Thomas certainly doesn't need any real introduction at this point from me, but he has inspired me to really keep looking at our long-term care setting and how do we change it. Professor Marge Cantor was another one of my professors at Fordham who did landmark research on the informal caregivers taking care of people at home and how they provide so much service that our government could never afford to pay for the amount of work that's being done by families and caregivers. Sister Rita K. Kerr, Dr. Jack Rowe, Dr. Jane Barrett, and Greg Shaw have been long-term supporters of my activities. Dr. Cynthia Sewin, And, you just go on. And Itzhak Brick, who is going through a torturous situation right now in Israel, just is a real fine man. And, so I've been lucky to be standing on the shoulders of so many leaders in our field. And that's, there are more. And, if you just think of it, what your own network is, that's important. So I've been lucky to consistently work on the field of social work. I started in the field of child welfare. Initially, when I went to the University of Wisconsin-Milwaukee, I was guided toward being in the field of education. But when I was told that, you teach for a while, then move up as a man in elementary education to the superintendent's level, I said, I want nothing to do with administration. 45 years later, that's all I've done is administration. So it's kind of a, interesting parallel. So I think that's enough about me. You introduced me and I had to look behind myself to see who is she talking about.
No, thank you very much, Bill, for that. And I guess to take us also back to the task at hand, which is really to discuss how we can improve social functioning in long-term care settings. And before we go into any technical questions and some of the general content of today, I just want to set the scene a little for everyone to a degree and just to hear a little about your thoughts on long-term care as a whole. So could you share with us the role of long-term care settings as part of the continuum of care, particularly in the context of a rapidly aging global population?
I participated in a cafe not too long ago where I heard one of the speakers say that all nursing homes are bad or death traps. And that's a myth. And frankly, it's something that has to be dispelled. Now, none of us want to move into a nursing home. I understand that. But how many of us are preparing to stay in the community for the long term? Many people can't stay in their community. And the long-term care or nursing home program is really a vital part of the continuum of care. And frankly, nursing homes have been stepchildren to acute care throughout the years. Hospitals have always enjoyed much more resources from our state and federal government than any of our nursing homes have. And nursing homes are not perfect by any means, but I think we have to stay away from the broad brush type of picture with nursing homes. We know there have been scandals. We know that there have been poor care. And we also know that the poor actors have not been exited from the field fast enough. So, there's a lot of blame to go around for that. Fortunately, my whole career has been in the field of not-for-profit long-term care, so that any surplus at the end of the day goes into funding our resources or developing or continuing our continuum care, building new facilities, things of that nature. And the nursing home gets a bad rap. And yet I've been in some phenomenal nursing homes in my career throughout the country. I was past chair of Leading Age. Before that, it was called ASA, the American Association of Homes and Services for the Aging. And we have over 5,000 providers throughout the country that do some remarkable work in taking care of the elderly in their community. Some of them through housing, some of them through assisted living, et cetera. And yet it's important that we continue to evolve and change. I was recently at a conference where Mr. Michael Dowling, who's the president and CEO of Northwell Health System, said it's a multi-billion-dollar health system in New York. And he basically said that only 44% of their resources come from the acute care setting. Now they are really focusing on getting the services out to the patient in the community. And that's where it should have been 50 years ago or 100 years ago. So, it's an evolving system. Nursing homes are slower to evolve. We probably don't have the resources to turn as quickly on a dime as hospitals may. But we also know that if you're not surviving in this environment, you go bankrupt or you go out of business. So that's just a piece of it. But the long-term care community really does have to rely and recognize the value of their services and how they play in the whole long-term care and healthcare model, even working with hospice programs. So it's you have to take a risk and you have to move on.
Yeah. No, thank you very much. And, as part of the long-term care system, it really does serve people of a variety of different needs. So this can extend beyond the exclusive assistant for function and medical care. And with this, I would really like to hear your thoughts of why improving specifically social functioning and psychosocial services is so important in these settings as a whole.
Well, why don't we start first with just defining social functioning? And it really means that we have to refer to how well somebody interacts with and relates to others in society or in their community. It includes social skills, social cognition, and the ability to build relationships. Now, many of the folks that are coming into nursing homes, frankly, are very compromised and are very sick. And sometimes they come to the nursing home too late. And it's usually at a time when family can no longer support them, either independently living or with them. And, you have an interesting dynamic that comes up where, the seniors coming into care are resistant, they're frightened, and family members are angry that they weren't able to keep mom at home longer or dad at home longer. And so you have an interesting dynamic going on, and they're transferring over the most valuable resource, their loved one, to you as a provider to care for them and to give them the respect and dignity that they are entitled to. I've worked with dementia units, and I always advise the family members with Alzheimer's patients or other forms of dementia that you play to the moments of lucidity. You meet with them, they're not going to be confused all the time in most cases. They will have those glimmers of hope or glimmers of clarity where you have to feed into that and participate with that and support it. And you'll be surprised. Sometimes that happens through different modalities to really improve the situation.
Thank you very much. And I guess one of the questions we have in the chat, and which would be a great one to integrate now with this context, is from Mr. Shmuel Yerushalmi, who joins our cafes weekly with great questions. And his question is in regards to the role of government as a whole. So what is the role of government and state authorities in the context of improving social functioning and long-term care? And specifically, whether you can speak a little, perhaps to lower socioeconomic settings and groups.
My frame of reference will be from the United States. And my bias is that I believe that government is over-regulating many of our long-term care programs. And it's become a multi-billion-dollar business in itself for government to regulate and to protect our facilities, so to speak, or our residents. And, being part of the not-for-profit community, we always said that you lead with quality and you have good quality programs, which is so very, very important. Yes, there are bad actors, and government should come in and remove those bad actors. We've had situations where resources that are scarce are given to profits of administrators or owners of different properties. And that's a problem, or misuse management. That's a problem. Government has a responsibility to deal with that. But the amount of regulatory issues that we have to respond to in many cases is obscene, and it takes our professional staff away from the bedside, away from caring from the individuals. So regulation has a role. Let me tell you, I believe in it. It's setting standards, setting quality measures. It's identifying where we can improve what we're doing. But it's got to remove the gotcha type of mentality that we see in many forms of regulation where they catch you. I've gone through far too many surveys in my life where I could tell on day one as the team comes in whether or not we're going to have a good survey or a difficult survey. And it's, they all bring their own luggage to the event. And, and you're dealing with hundreds of staff that can tank you with one bad answer, one bad action. And you can't, that's the problem with the broad brush type approach. Now, again, if there are bad actors, get them out of the field. Nobody needs to have someone who's going to be sleeping on the job or abusing our residents and clients, but you need to do it judiciously. And I just think that government has a huge role. Frankly, part of our problem now is that government has not allocated enough resources to long-term care. And as in times of scarce or difficult economies, long-term care usually gets a cut rather than the needed resources that they have, that they must have in order to hire the staff. Staffing is a critical issue for the field of long-term care, and to recruit people. And when we demonize nursing homes, who's going to be encouraged to learn how to run a facility? Who's going to be encouraged to go into a nursing home unless they have a positive experience? So it's, that scene is all really very much set by government. In terms of lower economic folks, we're fortunate in New York to have a very robust Medicaid program, so that when a patient comes into a nursing home in New York or a resident, they really don't know who's private pay or who's on Medicaid. And Medicaid fills the gap. Doesn't meet all of our costs by any means. So not-for-profits as a whole will generally go out and do fundraising to help fill those gaps. And but frankly, that's an opportunity also to tell the world or your community what a valuable resource you are to your community. So it's something where I've enjoyed great facilities that have had wonderful reputations. Are they perfect? No, but they do much more good than harm. And but when government starts cutting away your reimbursement to the point, and this happened in my situation, where we recognize that within 3 years our organizations would be bankrupt, we decided to sell the nursing home when we could. And now we're moving toward morphing into more like a foundation. But because our board would not support poor quality care. Boards are very important to running these not-for-profit corporations, and they have an awesome responsibility. And it means that they have to have their finger on the pulse the whole time.
No, thank you very much for that. And I encourage folks to type any questions they have for Bill in the chat. But Bill, switching gears a little, I wanted to talk about the integration of long-term care, but in communities. So can you share with us really the importance of thinking of long-term care as part of a larger community rather than an isolated setting, and how this can also inversely relate to improved social functioning in these settings and for residents?
When I became an administrator of several facilities through the years, or president, I really saw that I was sitting on a tremendous resource for the community. And sometimes you have to risk and use your facilities, use your community to help sell your message. I know that many of our nursing homes, which are handicap accessible, become polling sites for elections for local people to come into the facility to cast their ballot on local, state, and national elections. Well, that's a harmless way for somebody to come into the facility. They're not sick. They come in to see, smell, and touch the facility, and then they leave. But it's a resource because many of our communities don't have handicap accessible buildings for voters to actually go into. So it becomes a resource from that standpoint. Another example, I lost my wife about 3 years ago, but about 25 years ago, she was working on her master's. And part of it, she was working with a fund development professor who charged them with, okay, set up your project and go get some funding. And what she did was she put together this gallery, this application for funding for a gallery in a long-term care facility. Now, outside of my office at St. Caberni Nursing Home, we happen to have a lot of bare walls. And we also were in a community where many artists were living, and many of their pieces of art were under their beds or in closets. So we opened up a series of shows where we would have experts in art come and jury the shows. We were able to actually get $10,000 to do a proper lighting in that particular area. And that gallery continues to function today. And so it's another way of where artists can come into your facility. We run programs around them. Residents have something else to look at but bare walls. And family members and residents get a chance to actually have a different type of visit. So it becomes something that I think is very meaningful. We did some tweaking on my wife's graduate work, and we were able to get a bank to come through and fund it. And then the Arts Council in Westchester County helped us set it up. So that's a way of using your resources in your facility. I never thought I'd be opening up a gallery, never. Other resources that we've been able to do is using our homes, our facilities as education centers. We would have nurses come into our facility and shadow other nurses, nursing students come in, LPNs, registered nurses. And they have to cycle through different types of settings, but all too often they end up at the acute care setting, which is a lot sexier than the long-term care setting. So if they can go through peds, or they can go through an emergency room, or they can go through general surgery, et cetera, we usually lose the nursing graduates to that setting. But we played a part in it. And sometimes down the road, one of those students will come back to us, or one of our physical therapists will come back to us and see the value that they contribute to the field. So you could be an education center for the community at large. And it puts you in a position then to be part of the research modality, where you might become a site for different types of funded projects. So it's another source of revenue coming in, and it stimulates your staff to see that there's something good going on in this facility that sets us apart from others.
Thanks very much. And I love the idea of education centers. I think that is very incredible. Now, looking through the chat, I see Jane. Jane has a question in the chat. So Jane, would you mind unmuting to discuss a little?
Sure. Look, thanks very much, Bill. I've got two questions, but I'll pose the first one. Increasingly, there are marginalised populations that we need to be conscious of and take care of and provide services. And I'm thinking particularly of older homeless people and older people with addictions. To what extent can residential care in some form provide them with, shelter, care, love, food? Because in Toronto, I see many older homeless people and increasingly in the winter. So I'll leave it at that question because it's a big question, and I'm really interested in your views about that.
Well, the question was so narrow that I thought I would broaden it a little by saying that mental health is a huge, huge problem in our communities. And, you know, I did run at one time 7 senior centers in the Bronx, New York. And we put out over 1,600 meals a day to Meals on Wheels. And we have high-rise buildings, so therefore we had volunteers or staff that would arrange with Meals on Wheels to get the food up to the higher floors, so people had their food. And you know, there are ways of replicating our models of service in senior centers and reaching out. And you know, again, you have to really get the professionals, the psychologists and others who can really reach out to this marginated population. Homelessness is a huge issue, and it's only getting worse. We're seeing that mental institutions have discharged so many patients from their institutionalized care that now we have a new form of homelessness. And these people are very compromised and just don't have the resources or family anymore that's going to be a buffer for them and support them. But we have models of where we can bring people in for short periods of time. We try to work with some of the homeless situations. I was talking to a colleague just the other day who has worked for 30 years in the field of housing for the elderly. And she's chairing a board in New York City whose sole mission is to create housing for homeless people. And now look at the skill set that she has coming in to look at, you know, what type of facilities can you build, what's reasonable, what'll meet their needs, not Taj Mahals, but what will meet their needs. And we have a huge vacancy issue with our real estate throughout the area. Well, how much of that real estate can be modestly converted into housing or shelter for folks? It's a huge initiative, but I think, you know, we try to partner with others. I serve on this Westchester Public-Private Partnership here in Westchester County, and that was a mix of not-for-profits and businesses that used to work together on how do we solve problems in our community. And one of our staff, who's a lawyer, spends a great deal of time in the courts representing people that are being evicted from their houses and with no place to go. Well, you know, so they fight that. They fight the landlords. You know, but who has that representation in the homeless community? And yet it's a huge need. So, you know, you have different social justice centers that are beginning to pick up more hands-on, but we're only hitting the tip of the iceberg because the numbers are overwhelming us.
Thanks, Bill.
Thank you very much, both. And I know in the chat we also have Mr. Greg Shaw posing a question. So, Greg, would you like to talk a little?
Yes, thanks, Bill. Look, it's a question that I think is really at the core of long-term care to a large degree, and it's you know, LTC funding is really designed to reward frailty and functional decline. You know, so, and it's historical forever and a day. It's the more functional decline you've got, the more money you're going to get from government. But how do we get to a place where functional improvement is at the core of long-term care? We're actually trying to improve function of residents without jeopardizing the core funding that organizations may receive.
Well, thank you for that softball question, Greg. I think what you want to do is look at some of the pioneers. One that I mentioned, Dr. Bill Thomas, does the Eden Alternative or greenhouse model of taking care of people. And it's usually a smaller number of people in a residence. And he believes that many of our programs need to be changed where the policy incentive really does go to reward the facilities that are doing exactly what you're looking for, to reward them with revenue. so that they can continue to do it, because much of our revenue gets sucked up into the high-tech acute care side. And, we get a fair amount of money in long-term care. And long-term care can be set up in smaller areas. And we said, well, Dr. Thomas, you can't build those homes, those greenhouse homes in urban areas. Well, but you can. And we have models of it now in New York City where one floor will be an evergreen model. And, so that it's a start in that direction. Now, is it fiscally responsible? I think it's mandated that we use our resources to reward that type of program. I don't know if that helps, but Dr. Thomas has a wealth of experience, and he believes that public policy has to change so that we reward those that are dealing with experimental and good success outcomes.
Thanks, Bill.
Thank you both very much. And I see that I missed earlier Dr. Cynthia Stewin's question on prevention across the life course. So Cynthia, would you like to pose your question to Dr. Smith?
Absolutely. And actually, it's a good question to follow up Greg's, because it really is, I want to ask you, Bill, about this, given your long and rich tenure.
A little louder, Cynthia. A little louder.
Given your long and rich tenure in this field, what role does prevention and just the tenets of the decade of healthy aging? Because if we have more accessible communities, if we have more accessible homes, more accessible public transportation, that sometimes, given an acute episode, a nursing home might be a revolving door. You go for a brief stay, you come out to a community that has the supports for you. And I just, prevention is a life course, lifespan issue. And in our crystal ball from our third age, what do you think the likelihood of that? I think just given the demographics of population aging, all of the continuum is going to be needed and in greater number. But helping people stay healthy across the lifespan will preserve various resources over the course of one's life. So what do you think of that?
Well, I think, first of all, prevention starts with the individual. And it doesn't happen when you're in crisis. It happens as you grow. And I'm not a very good example of going to the club to exercise, but it's what you eat. It's how you move. It's how you get up early every Friday morning. It's, how you challenge yourself to reach out to, get yourself in good shape. It's, just yesterday you saw me with a cane. Now, I haven't had a cane ever before in my life, and I think I'm done with it now. So, it's a matter of where you use the adaptive devices that you need at the time, and then you move on. You rely on family and friends. I know you're a caregiver already in your own situation, but, it's where family steps in for the short term to get the loved ones back up on their feet and moving around. And they want to be moving around. But prevention is critical, and we don't put enough money into prevention. We simply don't. Our infrastructure in our communities is pathetic. I started off talking about how nursing homes have handicap accessibility for people to vote. Go try and walk down a sidewalk sometime without breaking your neck. There are crumbling infrastructures. Go try to get onto a subway. Well, you can only get on it if you can get down 3 stories through an escalator that hopefully is working. And you hope that where you get off, there'll be escalators going up to get you out of the tunnel. But it's a real issue. Handicap accessible taxis, big problem. I have great difficulty getting in and out of a taxi. Well, we cramp them so small that you can hardly get in. If you have long legs, you can hardly get in. So it's this design is very important. And we're beginning to see that prevention is coming into the whole field of design. And I think design is very, very important. There's a conference that goes on every January in Las Vegas, where they will have largely technology and different types of adaptive devices, and they'll get over 100,000 participants at that convention. And they're out there to try and see, what does the market bear? What does the market have? So I think it's a combination of one, self-responsibility. Two would be, okay, what do the communities have to do to with the infrastructure to actually ready themselves for the community? We know that our seniors are growing in large numbers. We know that we will have many more needs as these seniors grow. Many of them are outliving family members, and that's a problem, because where's your support system? But I think that it's prevention. It's a matter of really taking one step in front of the other.
Thank you very much, both for that question and that answer. And I see, Mr. Ralph Hubel, you have a question regarding how we can measure impact as well. Would you like to unmute to speak a little more on your question that you posted in the chat?
Sure. Yeah, I'm just curious about, again, when trying to increase social functioning in facilities and things like that, one of the things that always comes up with the resistance is what's the bottom line? How much is it going to cost me? And what positive benefits am I going to get out of something like this? Or are we going to get out of something like this? So I was just curious about your perceptions of, what are the results of increasing social functioning for residents in facilities?
A very good question. Thank you. I think that I'm a student of qualitative research, not necessarily quantitative research. In other words, don't look just at the numbers, but look at how does the quality improve the life of those who are serving or those who are studying. And I bring up another example. I had a very fine contact back a lot of years now with Dr. Carl Pillemer, who was at Princeton, and we did a living history project with our residents at the nursing home in the Bronx. And there was no money exchanged, but there was time exchanged. And we had researchers come in, train the social workers how to do a battery of questions with our residents. So it was all free participants. And it would go through their life cycle, like where were they born, how many family members, all the way up to where did they live, what kind of work, etc. And then finally, what brought them to long-term care. So every week we would have a different series of questions. Then Carl would take the answers that were taped back to Princeton, and they had them transcribed. The following week, they came in and edited those comments. And then they started another series of questions. Now it's a living history project. It ended up being that every participant, and there were about 30 out of 386 that participated in this study. And what the university did was actually collect all of those stories and put it into a binder, and they could have as many copies as they wanted to give to their family members. Now, when an old person dies, you lose a library. We actually saved 30 libraries by passing this along, and we had a graduation ceremony and all that jazz. And it's a matter of just taking a risk and doing something. I think we don't measure the effectiveness of the gallery in a long-term care facility. How do you know how many visitors you get? Well, you could count all that, but you could also have a smile on somebody's face be a measure of what's going on. One of the most successful recreational therapists that we had was an actor that many of you may know, Dominic Chianese. Dominic was in Godfather. He's been on a number of big time shows, but he lived in our community. And once a week, he would come over with his guitar and simply wander the floors, go into residents' rooms and play them a song in Italian or Irish or whatever. And the faces lit up because music was important to them. Now, we got him involved because his son was doing a confirmation project, service project at our facility, and the whole family adopted St. Gaberni Nursing Home. So it became a situation of where, you know, you use the resources in your community. Now, my staff really had a problem with Dominic in the beginning because, you know, he wasn't documenting his visits. And I was like, oh, give me a break. You know, you can't document this happiness. And he would do groups like that. You know, but it really goes down to the people the staff that are receiving guests coming into your facility. Are they pleasant? Are your staff attentive to the needs? Or do we hear the horror stories of where I had to wait 2 hours to be toileted? Well, that seems to be unrealistic and unreasonable. And yet it's a reasonable complaint. And so you want to see, do you have enough staff to facilitate all this? And over 80% of our revenue went into staffing. So it becomes a very, very costly issue. And then when we became unionized, it brought in a whole new series of issues that we had to deal with in terms of protecting the rights of the employees versus caring for our residents. So, you know, they don't teach you that in social work 101, but, you know, it's live by example. I hope that helps.
No, that was absolutely incredible. And thank you very much, Ralph, for posing such a great question as well. And I know Miss Sarah Cruz, she's a part of the IFA, and she has an interesting question regarding staffing, which could relate to this as well. Sarah, would you like to unmute to speak a little on your question?
Hi, thanks, Roxana. So thank you very much, Bill, first of all, for sharing all of your experiences today. So when you were discussing the staff and their experiences working with guests and visitors to the home, I was wondering if you could speak a little bit more to what are the factors that you feel contribute to staff wanting to work in long-term care? We know that it can be hugely fulfilling, but obviously we know that also it's a very difficult job. So yeah, would you be able to speak a little bit more to that?
Sure. I think certified nursing attendants is probably one of the most difficult jobs that we have in our whole field. Nurses are also very, very taxed. They have large numbers of people that they are responsible for and short periods of time when they can meet their needs. Many of them don't even get lunch. Now that becomes a problem. You need to really set up an environment that supports your workers and encourages them to come to work. We do different types of events for them to celebrate them, Nursing Aid Week, Nurses Week, etc. But you have to do it throughout the year. And it really calls for you, one, to pay them a proper salary and to advocate. We do a lot of advocating with our government on the state level, which is the primary payer, to make sure that we get enough resources to cover our salaries and our benefits. They need benefits to survive. Most of the people that are working in our facilities are not single. They have families. So after working a hard 7.5-hour shift or 8-hour shift, they go home to work another 8 hours with their family. So we need to be very sensitive to that. And it's not just women, it's men too, that have to have, you know, that type of respect. But I think it's also how we treat the employee. If, you know, I used to, I had a new degree, I called it, or someone shared it with me. And it's an MBWA, and it's management by wandering around. You know, administrators need to get out of their office and get up on the floors, get to meet your staff, get to say hello. How are things going? How's your family? And I've done that. And some of these aides I still am friendly with today, and I haven't worked in that facility for 20 years. So it's a matter of you reaching out to them, touching them, and finding out, and oh, let me see the pictures of your grandchildren. Well, how many people do that? And that creates an environment that's attractive for workers to come back to work. The COVID pandemic was a nightmare for us. And we've heard a lot of horror stories through this area. And yet we've had staff that have come to our facilities day in and day out, working double shifts and not bringing in disease. And you didn't have the resources of a family member who's helping care for that loved one in the facility because we restricted them from coming into the building. Well, that was kind of stupid. But anyway, that's public policy at its worst. But we understand what it was, protection, infection control. But, you know, it's a matter of, you know, using common sense and reaching out to a person who's having difficulty. If they lost a family member through death, I can't tell you how often my staff and management would go to funeral homes to offer condolences. I mean, it doesn't cost us anything to do that. It's a matter of celebrating a new birth. It's a matter of celebrating weddings. So it's a matter of you really participating as part of your community in the greater community. And I think that's what keeps people coming back to work. I've worked with staff in long-term care that have worked there for 30 to 40 years. And, you know, we also try to consistently keep them on the same unit so that they are identified with that population. They know the routines. They're not floating, which leaves the impression of being insecure and, you know, losing their own identity. So, you know, I think that those are just some of the things that we do or have done.
No, thank you very much, both. And slowly coming close to the hour, but I do see we have a question from Miss Naomi D'Souza on her experience in being involved in long-term care settings, and specifically the aspect of family members visiting residents. So Naomi, would you mind speaking a little on your questions and perhaps asking one or two of the three? I am happy to also, oh,
Um, I've been involved for 14 years. How many years now? 19 years, and I was involved with all the organizations helping in long-term care. And I personally, and this is my opinion, concluded that there cannot be improvement in long-term care with all the other things you all are doing without the family members being involved in the care of their resident. They have to be involved and they have to attend the family council meetings to hear what changes are being made, to make improvements so it goes back to the ministry and they do things. I'm 80 years old now, and I'm still keeping the ministry informed of what changes as people contact me. And the sad ones are those who don't have family members, or those that are on PGT. PGT means, what's it called? The government, anyway, some family members don't have socks, don't have underwear. We help with the staff to buy them those things. So when you say, you know, you have these management by walking around, they don't have time. Ever since cell phones came in, they don't have time to look after these people. So where's the socializing? I used to go around.
I think, first of all, the cell phone should not be operational while people are working. They really have to be dedicated to the patients. Now, I know that there are emergencies and all that, and you react to that. But if I catch staff on cell phones while I'm walking around or wandering around, I challenge them. Why are you on that call? It can't be a business call that you're on. So anyway, so that'd be one reaction I would have. Families are critical to the field of long-term care. And we need to support our families to really participate in a much more integrated way with our nursing homes or long-term care systems. we do family council meetings also. We may have 50 to 100 people at a family council meeting. And we're soliciting, and sometimes those questions family asks are difficult, but sometimes they're not. Sometimes they're very fixable. I had another situation of a resident, Gracie, who I knew for 20-some years. And she had a very important caregiver, her sister, who on her mother's deathbed promised to take care of Gracie. And Marie would get on a bus from the South Bronx and travel up to Dobbs Ferry in Westchester County every single day. And she would be with her sister and attend her. And her sister was a difficult patient. She had MS and was bedbound. And with MS, you have psychological problems also. But she would torture her sister if she was a little bit late or if she didn't do something exactly right. Well, we had a responsibility to provide support to that family member coming also and making it a little easier for them. And, when she finally passed, we had to support her to, know the great loss, because her life was thrown into shatters because she lost the one that she loved the most. And, and yet it was a burden for that person. So families will be very attentive. It's easier for a family member to be argumentative with you in terms of questioning why you're not responding fast enough, or I need the clothes, or I need the this, that, the other thing. But we had auxiliaries that would help us with all sorts of funding and all sorts of clothes. And we'd have shopping sprees coming into the facilities where carts of items would be brought in several times a year, and families were invited to pick out with their loved one, what would they like to wear? So it became another activity, but it met those needs of, giving them the essentials of living in a long-term care facility. It's not like being at home. And everyone's entitled to that respect and dignity.
Thank you very much. Thank you, Naomi, and thank you everyone for all the questions posed. And I think just one last question on my end before we go into the key takeaways is, Bill, how do you see the field of long-term care settings shifting just in the next 5 to 10 years, and specifically with attention to social functioning as well? Are there any innovations in care models that we should be looking at in this context?
Well, I think clearly Dr. Thomas's work is excellent to review because of the evergreen model is a very exciting model to look at. It does have a need to be adapted to different types of community settings, but there's a lot that we can learn from them. I think that Dr. Pillamer's work in the area of ethics in long-term care is also a very fine resource for us. We have to just keep learning and changing. And when I heard the CEO of a multi-billion-dollar hospital say, listen, only 44% of our revenue comes from acute care, the rest is coming from our community operations. That's a huge shift. Now, public policy has to shift. Public policy has to reward those facilities that are really living on the edge and changing and really challenging the way we've done it before. So I'm a big fan of long-term care. I think we also have to be very careful not to put everyone into a bad box. We've had advocates for seniors in long-term care basically say, well, all nursing homes should be closed. Well, we close all mental hospitals. Where are those people? They're on the streets. What are we talking about here? How do we value the older person through their end of their later years?
Thank you very much. Thank you for that, but also just this incredible session. And I would love to hear your key takeaways to share with